Greetings, how are you? My name is Deontay Marquis, and I am a family nurse practitioner and registered nurse. And today, on behalf of my ALF training, we will be discussing for the next hour stroke, specifically causes, indications, and caregiver recognition. And I'll get into that more in depth as our presentation moves along and exactly what I mean by caregiver recognition. So let's go ahead and begin. So, as you can see, stroke causes, indications, and caregiver recognition presented by myself, Deontay Marquis. So first, I always like to review over our course objectives, and the course objectives are what we plan to accomplish, the specific topics that you will understand by the end of this presentation, and what I expect you to be able to do with the knowledge that is presented here today. So our first course objective, at the end of today's presentation, you will be able to understand and describe what a stroke is and what can cause a stroke. Our second course objective, at the end of today's presentation, you should be able to discuss the difference between the three different types of strokes, and those are a hemorrhagic stroke, an ischemic stroke, and a TIA. And also with each of those different types of strokes, there are pretty much the same caregiver implications, but some are a little more specific to one than the other. So we'll discuss those few small differences between them. But more importantly, I want you to be able to verbalize specific implications to a stroke. So we'll get into that today as well. Third course objective, you will be able to identify your role in the care of a patient suffering from an acute stroke and identify appropriate actions that you should take. If you notice a patient is suffering from a stroke, what can you do, whether you're a nurse, whether you're a nurse's assistant, nurse's aide, what can you do to assist in the care and improve the outcome of this patient? Because we all play a role in our patients' care and their well-being, whether it's a smaller role, a larger role, we all play a role, and it takes each of us to step up and fulfill that role and to know what that role is in order to make sure that that patient has the best outcome that they can have. Our fourth course objective is you will be able to discuss and identify indications of a stroke. So what are we looking for that can clue us in our assessment or interaction with a patient that can give us an indication that they may be having a stroke? And last but not least, our course objective is you will be able to discuss caregiver interventions and considerations specific to patients who have already suffered a stroke. So what can we do for those patients? What are they going to be relying on us for? And how do we meet their expectations from us to give them the best care that we can? And after we go through all that information and we check off each of those boxes for our course objective knowledge, we will take a short quiz, a 2-question quiz, just to test our knowledge and see if we are indeed retaining all of the information. So our first slide, I want you guys to understand why stroke and being knowledgeable about it and what to do, what it looks like, how it's treated. Why is that important? Why is that of the utmost importance? Well, because time when a patient has a stroke is equivalent to their brain. So as you see here, time lost is brain lost. Every minute counts. So I'll put here some data, 120 million neurons, 830 billion synapses, and 714 kilometers of myelinated fibers are lost each half hour after a stroke. So that means if you notice your patient is having a stroke at 1 p.m., or they seem to be having symptoms that resemble a stroke, but you're not sure, and then an hour and a half later, you come back and the patient wasn't just tired and groggy, but they indeed were having a stroke, but you weren't knowledgeable of a stroke and able to uh, categorize their symptoms as a stroke. That ca- amount of brain that they've lost in that time can never be recovered. So time is very important. So when we think we notice a stroke, or a patient is having symptoms, what are we supposed to do? Well, before we get into that and what we're supposed to do, we need to understand a bit more about a stroke. So you see here, we talk about how important a stroke is. Time lost is brain loss. Every single minute counts. Well, what is a stroke? First of all, let's start there. How is all of that brain matter getting lost in a minute? Well, I'll tell you. A stroke is an interruption in sufficient blood flow to the brain. So if you'd imagine, as a kid, sometimes they wrap rubber bands around their fingertips, or maybe you had a bracelet on that was too tight, but something that stopped blood from flowing freely to a part of your body. So that part of your body, if you kept that rubber band around the finger, the tip of that finger would slowly die because it's not getting any oxygen, it's not getting any blood, it's dying. And the same concept can be thought of for a stroke. It's an interruption, insufficient blood flow to the brain. So if the brain is not getting the correct amount of blood flow that it needs, then it's not going to be able to function properly. And its inability to function properly is going to become evident in the way a person talks, their emotions, their ability to think, walk. Everything's going to slowly start to become affected, but specifically to what portion of the brain that blood flow isn't getting to. Now, what causes this? What causes this interruption in blood flow to the brain? Well, this interruption is caused by a clot, or sometimes the actual a blood vessel ruptures. So therefore, the blood is just spilling out into the brain matter and not transferring through the brain to the places where it needs to be through the blood vessel because it's ruptured. So the interruption in blood flow is caused by a blocked blood vessel, by a clot, or simply because the blood vessel has ruptured and there's no channel for the blood to flow through anymore because it's ruptured. Either of those scenarios leads to cell and tissue death in the brain. Without proper blood flow, the cells in the tissue will die, which is how we arrived at that astounding number of brain cells and synapses that die every half hour after a person hasn't had a stroke. And you can see here in this picture, they dissected a blood vessel to show that there's a clot here. And that, so you can imagine all the blood that's supposed to, that this blood vessel breaks off into different channels, so all those parts of the brain aren't getting enough blood flow because there's a clot here. So let's continue. So we talked in the objectives portion of this presentation. I mentioned that there were 3 types of strokes. So here are our 3 types of strokes. And I actually structured this slide to show how often each of these strokes occur. So an ischemic stroke, if you can see, it occurs much more often than a hemorrhagic stroke or a transischemic attack. And an ischemic stroke occurs, is the most common type of stroke. And this happens when blood flow through the artery that supplies oxygen to the brain becomes blocked. So that's what we talked about in the previous slide, where a stroke is caused by either a blockage or a complete rupture of a blood vessel. So an ischemic stroke is caused by a blockage of blood flow to the brain, usually by a blood clot. Now, a hemorrhagic stroke occurs when the artery in the brain ruptures, and then the blood starts to leak out. And this is caused, the blood puts too much pressure on the brain cells, which also damages the brain cells. So in a hemorrhagic stroke, there's not enough blood, and then the blood that's leaking out also damages more blood cells. So it's a very messy situation. And last but not least is a trans ischemic attack. Now, this is called a mini stroke sometimes because it looks like a stroke, it almost is a stroke, but the interruption in blood flow to the brain isn't long enough to be as damaging or to be considered an ischemic stroke. Um, it lasts no more than 5 minutes, usually very quickly, uh, maybe less than that, 2 minutes, 1 minute. I have family members who have had a trans ischemic attack and didn't know they had it until months later. And they happen to bring it up in conversation. And I say, oh, you had a stroke, you had a trans ischemic attack. Now, the most unfortunate thing about a trans ischemic attack is that since it isn't a real stroke and patients usually don't have any significant damage due to a trans ischemic attack, they don't take this warning sign as seriously as they should. Um, but so there are three kinds of stroke: ischemic, hemorrhagic, and a trans ischemic attack. So a trans ischemic attack is a mini ischemic. So it's just like an ischemic, except like I said, it doesn't block blood flow to the brain. And a hemorrhagic stroke is a bleed, a hemorrhaging bleeding. Okay. Now we're going to watch a short video just to give you a little bit more in-depth view of what the different types of strokes are.
Every 2 seconds, someone somewhere in the world experiences a stroke, and 1 out of every 6 people will have one at some point in their lives. Strokes deprive brain cells of oxygen and are one of the most common causes of death and a leading cause of preventable disability. When someone experiences a stroke, quick medical care is critical and can often help avoid permanent brain damage. But what causes strokes in the first place, and what can doctors do to treat them? The brain makes up just 2% of your body's mass, but consumes more than 20% of the oxygen in your blood. That oxygen is carried to the brain through a system of arteries. Carotid arteries supply the front of the brain, and vertebral arteries supply the back. These are connected to each other and divide into smaller and smaller vessels that get billions of neurons the oxygen they need. If the blood flow is interrupted, oxygen delivery stops and brain cells die. There are 2 ways this can happen. Hemorrhagic strokes are when a perforated vessel allows blood to leak out. But the more common type is the ischemic stroke, when a clot blocks a vessel and brings blood flow to a halt. Where do these clots come from? On rare occasions, a sudden change in heart rhythm prevents the upper chambers of the heart from contracting normally. This slows down.
Okay, so I just wanted you guys to see that illustration. It's done by TED Talks, so it's very good. Great graphics that they have there, just to give you a visual of what happens with an ischemic stroke and a hemorrhagic stroke, and the difference between the two. So we'll pick up where we left off here. So I stopped that video where the narrator was getting into what can cause that blood clot to occur, which would lead to an ischemic stroke. So risk factors of an ischemic stroke, the narrator was getting into changes in the heart rhythm. So I have separated the risk factors into modifiable and non-modifiable. So modifiable are things that we can change. Non-modifiable are things that we can't change. So modifiable, things that we can change. So these are things that if your patient has any of these or any 2 or 3 of these, it just increases their risk of having a stroke. And that's why it's very important for us to really hone in on our management of the patient's care to reduce their risk of stroke. And we can do that more if we have an idea of the risk factors that lead to a stroke. So high blood pressure, atrial fibrillation, smoking, diabetes, high cholesterol, coronary artery disease. And if they have had a TIA or a previous stroke, it increases their risk factors tremendously as well. So these are the risk factors that you want to pay attention to. If you see these on your patient's chart or notice them in their medical history, it should really clue you in to put forth a lot of effort into making sure that the patient is not smoking, making sure that their cholesterol and intake is low, that their blood pressure is well managed, that their diabetes, that they're taking their medication, they're exercising, and doing all these little things to just keep the risk of stroke at a minimum. Because as you saw in the video, it said it is one of the leading causes of debilitation. It is a lead debilitating disease in the US. So we really want to stay on top of that. And our non-modifiable risk factors, these are things that we can't change that place our patients at risk. It's heredity. So if their mother had it, father had it, race, it's more common among African Americans and Hispanic Americans. Gender, more common amongst females. And again, prior stroke and the patient's age. As they get older, their risk increases. So these are our risk factors. Now, we've identified the risk factors. We've used them to identify a patient that may be at an alarming risk for a stroke. Let's say the patient that we're taking care of had a TIA, has atrial fibrillation and high blood pressure, and isn't compliant with their medications all the time or their diet. We go into this patient's room one afternoon, and the patient just seems very confused, not sure whether it seems like the patient's looking for something and they can't remember where they put it. And we're having trouble understanding their speech. It seems kind of gargled. And then they tell you that they feel dizzy and off balance. This may seem like the patient it could be a number of things. It could be a low blood sugar. It could be a low blood pressure, which is why a stroke is so scary, because it is very severe. And we talked about how time is of the utmost importance, and all the brain cells that are lost every minute, every half hour with this disease. So we want to be very diligent in our assessment and recognition of symptoms that are consistent with a stroke. So what are those signs and symptoms? We have them listed here. Let's read through. Numbness or weakness in the face, arm, or leg. So if you think your patient may be having a stroke, I'll teach you guys the assessment to go through to quickly assess them to see if it indeed is a stroke. But let's just read through some more of these signs and symptoms. Confusion, trouble speaking, difficulty understanding speech. So they can't understand you, or they having trouble speaking themselves, so you can't understand them. Trouble seeing in one or both eyes. Trouble walking, dizziness, loss of balance, lack of coordination, severe headache with no known cause. So these are all symptoms that we need to look for. In my experience, I have taken care of patients who had a stroke and are recovering. So I've seen I've seen these symptoms, but not in the acute phase after the patient is already trying to recover from the damage that the stroke has caused their brain. And I've also seen a patient who is active, who had a stroke. Um, it's not like a notable event, like per se a seizure, where you can look over at someone and say, oh, that patient is having a stroke. It's very subtle symptoms. And unless you're communicating and engaging with the patient, you will miss it. And even when you are, just because our patients are sick, they're taking different medications, they're older, maybe they're not compliant, these symptoms can be confused or overlooked for something else. In my scenario, I was taking care of a patient who had a procedure in the recovery room. And because of the medication given during the procedure to help the patient stay relaxed and asleep, these symptoms, they all seemed consistent with side effects of the medications that the patient was giving. And it wasn't until the family member came back to visit with the patient and said that something was wrong that made me realize that yes, this something is wrong, and act on the situation. And indeed, that patient was was having a stroke, or had had a stroke at some point in the care. And this all happened in a matter of 15 minutes. But still, that is a significant amount of time in relation to a stroke. So those are our signs and symptoms. Uh, Now, nursing care. What do you do if you notice somebody is having a stroke? Well, for an ischemic stroke, a hemorrhagic stroke, or a TIA, your actions are generally going to be the same. If you notice a patient is having stroke symptoms, like we talked about here, then you want to follow the acronym ACT FAST. So FAST stands for face, arm, speech, and time. And you should act fast. So the acronym is imploring you to move quickly in consideration of the brain cells that die so quickly due to the lack of oxygen and blood flow. So, fast face, is the patient's face drooping to one side? Are they able to smile? When they smile, is it equal smile? So, if you walk into the patient's room and you think that they may be having a stroke, you can say, Mr. Johnson, can you smile for me? And that will be assessing the F in fast, or their face, for facial drooping. Maybe Mr. Johnson doesn't have facial drooping, but he is having a stroke because something's not right. So we move on to the A in fast, and the A stands for arm weakness. So you would say, Mr. Johnson, can you close your eyes? And he's sitting down, not standing up. If you believe your patient is having a stroke, keep them seated or lying down. Do not ask them to stand or allow them to stand. So A in fast is for arm weakness. So we'd ask Mr. Johnson, can you close your eyes? Can you hold out your hands and just pretend like you're holding a pizza box? So he could have his palms up, like he's holding a pizza box, and his eyes are closed. And we want to see if one arm drifts lower than the other. As you see in this picture here, this left arm here is drifting lower than the right, which is holding nice and steady. And this will clue us in that, hey, Mr. Johnson might be having a stroke and it's affecting his left side. So if Mr. Johnson's having a stroke and it's affecting his left side, then me and my experience in caring for patients with a stroke, I would stand on Mr. Johnson's right side, because if he's having a stroke, then I want him to be able to see me and hear me from his non-affected side. So, speech, difficulty talking. You ask Mr. Johnson, can you please tell me your name? Can you please tell me who the president is? Can you please tell me what hospital or what treatment center, or where are we? And you should judge his ability to answer the question correctly and the pronunciation of the words of his answer. If they sound gargled or inconsistent, or he's not responding correctly, giving you the wrong answer, all of that will clue you into whether or not Mr. Johnson is having a stroke. And last but not least, T is for time. You need to act quickly. It is much better to notify someone, whether it's a doctor or a nurse, that a patient is having a stroke, and be wrong that the patient wasn't having a stroke. Maybe they were tired, or it was due to a lack of, uh, it was due to their blood sugar being too high or too low, or a medication that they've taken. It is better to be wrong about reporting a stroke than to not report it at all. In my experience, nurses were sometimes hesitant to call a stroke into the doctor because they weren't sure if they were right or wrong. Now, mind you, I worked in the intensive care unit where a lot of the times patients can't talk or they've broken an arm or a leg. So it's difficult to use this assessment tool, and you rely heavily on speaking with the patient. And if the patient's taking a lot of pain medication or different medications, then their speech is at baseline not normal. So, nonetheless, um, report it if you believe it's a stroke using the FAST acronym and recognizing the signs and symptoms that we talked about here. Um, and you see our time here within 3 hours of the first symptom. That is when the patient needs treatment at a hospital within 3 hours of the first symptoms. So, if you believe a patient is having an ischemic stroke, which we talked about, is a shortage of blood supply due to blood clot, then we need to report it as soon as possible because that patient needs treatment within 3 hours of the first sign or symptom. Now, a TIA is, like we talked about, a serious condition, but it's a serious condition, a serious warning sign of something that's going to occur more than likely in the future. We talk about how the symptoms are consistent with an ischemic stroke, but much less severe and impactful on the patient's immediate health. However, just because it is not as impactful on the patient's immediate health as a true stroke is, it does not mean that a TIA does not need attention. So what should you do if your patient says, "Oh, they're confused for very brief, a minute. They say their arm feels weak and they can't see out of one eye, just suddenly for a minute." And then you tell them to rest and you're taking their vital signs. And before you can finish taking their vital signs, they tell you everything went away. All the symptoms went away. I'm fine. You should definitely report this to the doctor or to a nurse. And more importantly, you should note the time of the event. What time did they call you into the room, or did you enter into the room and the patient complained of these symptoms? What symptoms did they complain of? Oh, the patient said that they lost vision in their left eye, their right arm went numb, and they were very confused. So we got location and the severity. How numb was their arm? Were they able to move it? Were they able to raise it up very high, or they couldn't move it off the bed? So we want to note those symptoms because that's going to clue the doctor or the nurse into how severe this TIA was and whether the patient has a stroke that's impending within the next few days, within the next few months, or within the next few hours. Maybe this was a clot that occluded the blood vessel for a minute. Um, and because of that, it caused backflow to the heart. So there's another clot that's coming up soon. Or maybe this clot was able to squeeze through a larger blood vessel, but now it's headed towards a much smaller blood vessel where it will get stuck and cause a true ischemic stroke. So we want to make sure we consider all of those things if we note the patient complaining of those symptoms. Now, a TIA is, we talked about risk factors for stroke. A TIA is one of the strongest risks for an ischemic stroke because it increases your risk of having a stroke in 90 days by nearly 20%. Um, and within the first week, the patients are uh, at a very high risk to have a real stroke. So if your patient reports a TIA to you, or the doctor or nurse lets you know that this patient recently had a TIA, you want to first understand what a TIA is. That's a trans ischemic attack, very similar to a true stroke, and that the likelihood of this patient having a true stroke is very high. And so our efforts to care for this patient and reduce the underlying causes of a stroke must increase, or else this patient will have a stroke and they will suffer some type of permanent damage because of the stroke. And we don't want that to occur while this patient is under our care. So, what are those underlying causes of a stroke again? Well, we talked about this in the beginning. I'll reiterate here: heart disease, high blood pressure, atrial fibrillation, high cholesterol, and diabetes. Those are the main contributors and health modifiable risk factors that we can help change, control, manipulate, whatever it is. We need to do something to reduce this patient's risk of having a stroke. And if you're not at your facility with the patient, maybe you're outside of the facility, or someone is asking you 911 at the first symptom of a stroke, because we need to get the patient to the hospital ASAP because they need treatment within 3 hours. They don't need to just get to the hospital, they need treatment within 3 hours. And we all know sometimes how slow healthcare can move in the ER. So we need to account for all of that time. So that patient needs to get there ASAP. Now, last but not least, a hemorrhagic stroke. This is the third type of stroke we talked about. And a hemorrhagic stroke, we talked about how it occurs when a blood vessel bursts inside the brain. The blood builds up and it also damages tissue around the brain. Again, this is going to need emergency treatment. Um, there aren't any signs or symptoms that distinguish a hemorrhagic stroke from a TIA, from an ischemic stroke. They all generally lead to the same signs and symptoms. Now, a small change in what we should first be looking at for a hemorrhagic stroke, because there is bleeding involved, we want the patient's blood pressure to be lower. Because if the blood pressure is lower, that means the bleeding won't be as rapid or as severe, as opposed to if the patient's blood pressure is high. And if they have bleeding, then their blood pressure is probably high. So if a patient has a stroke, it's difficult, as I said, to distinguish between a hemorrhagic or an ischemic because they all have the same signs and symptoms. So if a patient has a stroke, you want to check their blood pressure, whether it's a hemorrhagic or ischemic. And you also want to check their heart rate. And you also want to check their chart or ask the nurse, is this patient on any blood thinners? Just so you can have an idea of what's going on with the patient, what to expect, and what information we can pass along to the doctor to improve this patient's outcome and the time that the doctor will need to spend assessing and preparing care for this patient. So, again, note the time that the symptoms appear, note what the symptoms were, how long are the symptoms lasting, where and how severe are these symptoms, are all important criteria that if you notice a patient having signs and symptoms of a stroke, that we need to act on, we need to document. So I pinned this poster here to my chalkboard just so we can see much bigger. Is it a stroke? Act fast, FAST. So we can see Mr. Johnson's face here, facial drooping, arm weakness, speech difficulty, time is critical. So face, arms, and speech. If that's all you need to really assess, if you can't remember all those signs and symptoms, you can remember act fast, face, arm, speech, time. And that is what we can use to quickly assess our patient and see if they are indeed having a stroke, if we think we are. And this is something you can do whether you're a nursing assistant, whether you're a registered nurse. This is a tool that you can use to more accurately gauge a patient's symptoms if you believe they're having a stroke. So now we want to get into specifically what is your role in stroke care? Well, your role is simple. Identify patients who are at risk of having a stroke and lower that risk. That's it. That's your role, that's your goal, that's what we are here to do. How can we do this? Lifestyle changes. It's important that we let these patients know you're not just doing this for today, for tomorrow, for this month. This is going to be a part of our new lifestyle for you. Otherwise, this other lifestyle uh, of being debilitated due to a stroke, unfortunately, that's going to be your new lifestyle if you don't adopt these lifestyle changes, which is taking their medication, exercising, ensuring that they follow a DASH diet, making sure that they take their medications, especially those for blood pressure and the cardiovascular system, um, and us monitoring their health and being rigorous in their exercise regimen to help increase the uh, strength of their cardiovascular system and keep them healthy. And again, I included who is at risk. If your patient has high cholesterol, high blood pressure, diabetes, or smokes, or has some type of heart disease, then your patient is at risk. And there's more that we need to be doing to keep them from having a stroke. As the patients get older, the chances of them having a stroke just increases and increases because they've been living with all of these risk factors, this high cholesterol, blood pressure, diabetes. They've been living with this and it's leading them down a narrow path. So we have to stop them, grab them by the shoulder and turn them around and say, "Hey, we're not having a stroke. Okay? We're going to do something about it." Whoops. Let's get back to where we were. Okay. Nursing assessment. So, uh, just to reiterate, um, no, just to introduce to you, when you believe your patient may be having a stroke, what can you do? What should you do? Well, you should have what they call a suggested, you shouldn't have, but you can, this will help you. They call it a neurologic flow sheet. And what that is it's like a log that you can use to write data down about the patient's clinical status, to assess the stroke that they just had, or even try to identify the location in the brain. But that's not necessary. We just want to make sure that we're documenting all the information that we can about this patient. Um, so, what would that information be? Well, changes in the level of consciousness or responsiveness. Because sometimes patients have a stroke and they're okay. Maybe they can still communicate, but their speech is a little garbled, or their arm is a left arm is significantly weaker than the right. But then, as we talked about, remember, strokes only lead to more strokes. So it's very likely that they will have another stroke if they're not following treatment protocol. So changes in the level of consciousness or responsiveness. We should note that, write that down. Were they easily awakened? Were they engaging in conversation? Well, easy to talk to them and hold the conversation. We should also make note of presence or absence of voluntary or involuntary movements of their extremities. Were they moving their arms, involuntary twitches or stiffening? Or was the arm laying flaccid, stiffness or flaccid of the neck? All of these things give us different indications, and we can share them with the doctor and the nurse uh, to make better decisions about how to move forward if you were the one that was there when the patient first had symptoms of the stroke. And remember, time. Note the time at the top of this document. If you're writing anything down, first write down the time, then start writing the symptoms, because we want to make sure that we're inside that window. That's the first thing that the doctor is going to ask, is what time were these symptoms reported or noted. Um, if you're a nurse and you're doing a more detailed assessment, eye opening, the size of the patient's pupils, their pupil reaction to light, perla. Um, also the color of the face and the extremities, temperature, the moisture of the skin, the ability to speak. These are just different neurological signs and symptoms that can clue us into the severity of the stroke that this patient may have had, whether it was a TIA or ischemic or hemorrhagic. So, um, our slide here, nursing care implications. Okay, what are our nursing care implications for a stroke? What can you expect if you're going to be taking care of someone who had a stroke? Well, these are the one, two, three, four, five, six, seven. 7 points of the patient's life that are going to be largely impacted by the stroke that they had. So these are the areas of care that you're going to be spending a lot of focus trying to help the patient, trying to help compensate for the patient's lack of ability to do for themselves. So, most importantly, impaired physical mobility. Patients who have had a stroke, likely sometimes patients, their entire left side becomes flaccid. And by flaccid, it means unable to move it at all. Sometimes they just have very increased muscle wasting or breakdown because they are so unable to move that muscle or use that muscle that it just becomes very, very weak. So, impaired physical mobility. So, for patients who've had a stroke, they're going to be heavily reliant on you to help them move, even rolling in the bed onto their side is difficult for these patients because they have had a stroke and the muscle is weak. So, for these patients to counteract that impaired physical mobility, we want to make sure that we're doing active range of motion and passive range of motion exercises to the affected extremity on this patient, just to prevent any contractures and maybe even giving them small sock weights, trying to work on their grip so they can hold it, making sure that they're getting the physical therapy that they need. So, impaired physical mobility, this is very large, which makes this is a very large component to try and compensate for the patient, um, because it affects everything that they do from showering, eating, bathing, sleeping. They're going to need our help. Decreased self care as a result of this impaired physical mobility. They're not going to be able to do anything for themselves until they build. They're going to, it's going to take a weeks for them to build the ability and the strength to do things for themselves that they were already able to do. And even then, they may lose the will to do them because it's so difficult and it seems like an impossible task for them. So they're going to need us to help them with, of course, changing, bathing, brushing their teeth, eating, and even eating can become a very serious issue because if all the muscles on one side of your body have become weak, that doesn't exclude muscles such as those in the throat or the mouth, which become weak. And patients who have a stroke are at high risk for aspiration or swallowing the food going down into their lungs because of the decreased muscle tone due to the stroke. So, we want to pay close attention to our patients when they're eating, decrease self care, and know that they're going to be relying on us heavily for this as well. Next, disturbed sensory perception. So this means that they aren't going to be able to see us as well, uh, won't be able to speak with us as well, but that's more for impaired verbal. So disturbed sensory, they're not going to be able to to see us or feel us or sense us. So that means that if the patient is laying on uh, let's say the remote is in their bed or their phone is in their bed, they're not going to be able to feel it if it's under that affected extremity or side of the body because it's all numb. So we want to make sure that for these patients, we're thoroughly checking the bed, making sure that the sheets are straight, making sure there's no crumbs in the bed or nothing in the bed with them that they can be laying on that would then cause skin integrity issues. And you'll see that's the last of these points here, risk for impaired skin integrity. And that is because of that lack of mobility, the lack of self-care, and the disturbed sensory perception that puts them at increased risk for skin integrity issues. Um, Moving forward, impaired urinary elimination. Sometimes these patients, as we talked about, as I just said, the muscles, uh, they have hemiparesis, so they're paralyzed on one side, or maybe just the muscle tone has significantly decreased. This doesn't just apply to the large muscles like in the legs or the arms. This applies to the smaller muscles like those in the bladder and the sphincter and the throat, like we talked about. So they're going to have sometimes impaired urinary elimination. So we're going to need to retrain them and help them and until they're able to heal and tone those muscles again, so that they can hold their urine and not have problems here. And as you can imagine, this is supposed to read thought process. These patients are going to have disturbed thought processes because they don't know what's happened to them. It happens so quickly, and it leaves the brain really uh, unable to think rationally and completely because all the synapses that used to be there are no longer there. So messages aren't getting sent or received properly. So this patient is going to have disturbed thought process, as well as an inability to communicate verbally very well. It's going to be difficult to communicate with these patients sometimes because either they have expressive aphasia, which means that the patient can't find the words that they want to use to make a sentence or to speak with you. So for these patients, it's best to sometimes have a word chart or a piece of paper and a pad for the patient to try and write out letters or pictures for the patient to point to what they need to assist you in being able to communicate with them. So that is very important. Something you can have a nursing care implication for these patients. Is in some hospitals I've worked at, they have almost like a placemat that sits on the patient's bedside table, and it has pictures of water, of someone eating, of someone using the bathroom, of someone walking, of someone watching TV. So the patient can just point to what it is they want to do because communicating with the patients can be so difficult and time consuming and frustrating, not for the healthcare worker, but for the patient. So we want to make things easy for them, but at the same time push them. But we want to be able to give them what it is they're asking for without getting them frustrated. So having that type of board or printing out some pictures can help them. And we talked about risk for skin integrity issues. So for this patient, you really want to make sure that you're elevating the affected extremities off of the bed using a pillow, that you're turning the patient, that you're getting them up out of bed, you're moving them around, you're applying lotion, you're checking the skin, keeping it from being excessively dry or excessively wet to reduce any risk for skin integrity. So these are the seven large implications of care that need to be considered for patients who have had a stroke. If you're caring for one of these patients, impaired physical mobility, decreased self care, disturbed sensory perception, impaired urinary elimination, disturbed thought processes, impaired verbal communication, and risk for impaired skin integrity. So it's a big task taking care of these patients, and that is why we want to stay on the other side of the care, meaning that we want to prevent our patients from having a stroke, and care for them on the healthy side before they have a stroke. And we don't want to have to care for them on this side because we're doing everything we can on the other side to prevent them from having a stroke and losing their freedom and independence, and relying on us so heavily. So that is it. That is it. Hopefully, by this point in the presentation, you get a sense for how important it is that you understand what a stroke is, you understand the people who are at risk for a stroke, what is expected of us, and why this all is so important and how it affects the patient. Um, so I'm gonna test your knowledge right now. We're gonna do this 2-question quiz just to see how well you were holding on to the information and understanding it. And let's begin. Our first question: if you suspect a patient is having a stroke, you should remember the acronym ACT FAST when responding to the patient. The A in this acronym is referring to which of the following? So, is the A in the acronym FAST referring to an ability to enunciate, an ability to move arms, assessing the patient, or the ability to answer questions correctly? So, which of those answer choices is the A in the acronym referring to, FAST referring to? This should be pretty easy. I tried to reinforce this acronym because it is one of the most important components of today's presentation. One of the most important takeaways of today's presentation is what is that acronym, how to apply it, and what each of those letters means, and how to assess the patient using those letters. So you should have an answer by now. Let's just see if it's the correct one. If you chose ability to move arms, then you are correct. If you remember, the FAST acronym stands for face, arms, speech, and time. We assess the face by asking the patient to smile and seeing if there's a droop to the one side or an asymmetrical smile. Um, and we assess the A by asking the patient to hold their arms out and close their eyes while sitting. Remember, anytime you think your patient may have had a stroke or may be having a stroke, we want to keep them seated because of the weakness and the risk for falls that's associated with the patient having a stroke. S, we want to assess the patient's speech. So you can just ask them to tell you their name, their date of birth, the president, ask him to say those things, judge how their speech is. Is it garbled? Is it confused? Are they able to answer those questions correctly? And then T, based on your findings of your quick assessment using the FAST acronym, do we need to call 911 or notify the doctor immediately? And remember that it's a 3-hour window to get treatment for this patient. So, moving right along, question number 2. A nurse is organizing her patients according to which is at the highest risk of having a stroke. Which patient should be on the list? Which patient should be first on the list, indicating they are at the highest risk of having a stroke? This is a tough question here. A patient with a history of obesity and high cholesterol, a patient with history of smoking, a patient with history of high blood pressure, a patient with history of a TIA. So which patient, based on the risk factors that we talked about, should be first on the list if the nurse is trying to organize her patients according to which is at the highest risk of having a stroke? So this nurse, she wants to divvy up her time, giving most of her time to the patient who needs it the most, to watch them and help reduce their risk of having a stroke. So which of these patients should get the most of her time because they are at the top of that list, because they are at the highest risk of having a stroke? Which patient? Give you a minute here to decide. Okay, we should have an answer by now. If you chose D, you chose correctly. Remember, we talked about TIA, trans-ischemic attack, being a mini ischemic stroke, but not having the actual effects. But I talked to you guys about how in my personal life and my professional relationship, patients and family members, they've kind of overlooked a TIA as what it was supposed to be, a very serious warning sign, and more so looked at it as, oh, I was so lucky that it wasn't a real stroke, but not taking the proper steps and precautions to make sure that they don't have a real stroke because they fail to recognize the severity of a TIA and what the body is really saying to them. It's saying, hey, your risk of having a stroke just went up 17% because you just had me, a TIA. So we want to make sure that our patients who have a TIA understand this risk, that we understand this risk. And if we come across a patient who's had a TIA, that we really rev up our efforts to make sure that we correctly address all of the modifiable risk factors, the high blood pressure, the diabetes, the smoking, the uh, the heart disease. We do everything we can to get all of those better managed. And by doing that, we can have a significant impact on their health and reduce their risk to have an actual stroke. So, course review, we should have everything checked off. Understand and describe what causes a stroke. Well, we know what causes a stroke. We know that it's caused by either a blood vessel becoming blocked by a blood clot, or that it's either caused by a blood vessel completely hemorrhaging. Um, and we know what a TIA is. We know the difference a TIA has from an ischemic stroke, and we know the difference between those two and a hemorrhagic stroke. And we know that the implications specific to each are generally the same, but when a patient has a hemorrhagic stroke, we really want to make sure that their blood pressure is lower because we know that a higher blood pressure indicates that the bleeding is more pronounced and it's bleeding faster because there's more pressure behind it. Um, our third objective, be able to identify your role in the care of the patient suffering. Our role is simple. We want to identify the patients who are at risk and reduce those risks. Um, and we know the appropriate actions to take some actions to help reduce those risks. Be able to discuss and identify indications of a stroke. Well, we talked about the signs and symptoms of a stroke. We talked about what a stroke might look like, and we talked about how to assess a patient for a possible stroke using the ACT FAST acronym. And last but not least, be able to discuss caregiver interventions and considerations specific to patients who suffered from a stroke. This was the 7 points that we talked about, all of those specific considerations specific to a patient who've had a stroke, things that we can expect as a caregiver to help our patient with, to help them overcome, and we can prepare ourselves for in their care. And that's it for today, guys. I want to thank you for spending this last hour with me. I hope that, again, through this presentation, you understand how serious a stroke is, you understand your role, and how you can use this information to not only improve upon your own skill set of caring for patients, but also to share with family as well and friends to help them understand more about a stroke. And together, we can use this information, share with our patients, and reduce the number of individuals having a stroke because it is a horrible disease. To me, it is one of, if not the most horrible disease out there. I want to thank you again on behalf of my ALF training. My name is Deontay, and have a good day. See you next time.